and welcome to our first patient education event this fall. I'm Barbara Goodman, and on behalf of the entire Cures Within Reach team, we're looking forward to an insightful dialogue on real-world data with you today, followed by a celebration of 3 organizations' efforts to impact patients through repurposing. Cures Within Reach leverages the speed, safety, and cost effectiveness of testing already approved therapies for new indications. The COVID-19 pandemic shined a spotlight on what we've known for over a decade. The fastest way to therapeutic impact is using already approved therapies in randomized control trials. We are institution agnostic, disease agnostic, and geography agnostic. And our funding of over $7 million to over 100 different projects has led to more than $68 million in follow-on funding. Most of our funding goes to first-in-human, proof of concept, or pivotal studies that can provide the catalytic effect for the next bigger studies. We fund projects whether they have philanthropic use or commercial value, focusing instead on finding viable treatments for patients with unmet medical needs. We currently have 33 ongoing and active clinical and preclinical trials in 28 different institutions in 21 diseases, not only in the United States, but 7 other countries as well. This includes clinical trials in adults and pediatric patients, in using pharmaceutical drugs, medical devices, nutraceuticals, combination products, and more. In the rare disease space, we cover cancers, neurodegenerative diseases, immune disorders, sight impairments, hearing loss, and so many other rare diseases. In the oncology space, this covers blood cancers, brain cancers, bone cancer, thyroid cancer, and more. In neurology, we include both neurodegenerative diseases as well as mental health, both PTSD and depression, including Huntington's disease, nerve trauma, and cerebral palsy are our ongoing projects. And over the last 18 months, we've added infectious diseases to our portfolio as well. Last year, we started 2 COVID-19 projects, as well as clinical trials in dengue and tuberculosis. Not only these 33 ongoing trials, but there are 15 more coming soon in pediatric rare diseases, 2 projects in the veteran space, as well as over 10 projects to be selected later this year for our diversity, equity, and inclusion initiatives, covering health disparities, underrepresented racial and ethnic minority PIs, as well as low and low middle income countries and clinical trials there. We are so grateful to our industry and philanthropic support. Too many to name here, but instead they're shown here on the slide. Thank you so much to each of these organizations for your commitment and support of our mission. In addition, we're grateful to our patient advocacy and disease organizations around the world who help get the word out about this event. In addition, we have an event on November 9th focusing on diversity and clinical trial researchers, as well as the diversity of clinical trial patients. Feel free to register for that event on November 9th. And now for the main event today, I'm going to hand it off to Claire Thibodeau.
Thanks, Barbara, and thanks to everybody who is joining us here today. I think that you'll really enjoy the program. I know that we're really excited about it. Talking about real-world data and what that means to patients. What is it? How is it generated? And how can it be used? We'll have a panel discussion on that topic, and then we will have time to take some questions from our attendees. So please submit your questions as you think of them via the engagement panel on the right-hand side of the screen. Following the Q&A, we will transition to our awards portion where we will recognize leaders in repurposing from philanthropy, industry, and from research. And we have great speakers for you on our panel. The panelists today will start with we'll start with our moderator, Ken Quinto from the Food and Drug Administration. We'll also be joined by Ryan Fisher from Parent Project Muscular Dystrophy, Mark Gallagher from St. George's Hospital in the UK, Anita Stewart with Blue Cross Blue Shield of Illinois, and finally, Stacy Lloyd, who is part of the American Medical Association, but then also wears another hat as a board certified patient advocate. So instead of hearing more from us, I'd now like to turn it over to our moderator, Ken Quinto, to start us off. Ken?
Hello, everyone, and thanks so much for Cures Within Reach for giving me the opportunity to moderate this panel as well as briefly present. I'm very honored to be able to do so today. I just want to give everyone an overview of FDA's real-world evidence program. Next slide, please. So why was FDA interested in real-world evidence? The real reason is Congress forced us to with the passage of the 21st Century Cures Act in 2016. It stated that the FDA shall establish a program to evaluate the potential for real-world evidence to, number one, support the new indications for drug approved under Section 505C, and number two, to satisfy post-approval study requirements. We were instructed to draft framework to be issued by December 2018, which we're going to describe sources of RWE, challenges, pilot opportunities, etc. We have an upcoming deadline for draft guidance to the industry to be issued by December 2021, so in a couple months. The standard, though, for substantial evidence remains unchanged, meaning that the level of evidence required for drug approval remains the same, whether using clinical trial data or real-world evidence, real-world data. And commitments are aligned with the Prescription Drug User Fee Act, or otherwise called as PDUFA. Next slide, please. So the FDA's real-world evidence framework was released in 2018 and applies specifically to the Center for Drug Evaluation and Research and the Center for Biologics Evaluation and Research, so CDER and CBER respectively. It's a multifaceted program to implement RWE, which includes internal processes, external stakeholder engagements, guidance development, and demonstration projects. Next slide, please. So the reason why I use, this is the distinction specifically that FDA makes between what's considered real-world data versus real-world evidence. What FDA thinks of real-world data is defined as data relating to patient health status and or delivery of healthcare routinely collected from a variety of resources. This includes electronic health records, medical claims data, product and disease registry, patient-generated data, including those from in-home devices and smart devices, and and other sources that can inform on health status, such as wearable devices. Do you mind going back one, Barbara? Thank you. What FDA considers real-world evidence is the clinical evidence regarding the uses and potential risk benefits of medical products derived from analysis of RWD. So this clinical evidence is generated through different studies designs, but not only limited to randomized trials, externally controlled trials, and observational data. Basically, the way I think of it is RWD is the sort of raw materials needed to create real-world evidence and the clinical evidence needed for additional drug approvals. Next slide, please. And so that's the real difference between what FDA considers RWD and RWE. And this is my last slide. This just goes to show you the different types of RWD and RWE that can inform drug trials, either observational trials or clinical randomized trials, with an increasing reliance on RWD as we move right. So, real-world data can be used to help traditional randomized control trials identify patients with specific inclusion and exclusion criteria and help enroll them, and use mobile technology to support different endpoints that the clinical trials are using. Moving all the way to the right, which are non-randomized, non-interventional observational studies, where observational cohorts are merely observed without an intervention plan for one or another group, or other study designs such as case control studies. So as you can see through this graphic, there is a very wide range of what FDA considers RWD to help in drug approvals for products that have been previously approved for a different indication. And with that short presentation, I'm happy to pass off the next presentation to Ryan Fisher.
Thank you so much, Kenneth, and thank you to the teams at Cures Within Reach. I'm delighted to be here to discuss real-world data through the lens of patients. I'm with Parent Project Muscular Dystrophy. We're an organization focused on finding treatments and improving care for those diagnosed with Duchenne muscular dystrophy, which is a fatal, rare genetic disorder diagnosed in childhood affecting approximately 15,000 patients in the US. It's characterized by progressive muscle loss and weakness, resulting in premature death of patients usually not reaching the age of 30. We were founded in 1994 by a mother by the name of Pat Furlong, who still leads the organization today. She lost 2 of her children to Duchenne, and since our founding, we've been focused on changing the landscape of Duchenne, which has included developing tools such as a patient registry in order to advance care and research. And you can go to the next slide. So why are patient registries so important? I actually like to refer to them more as patient-empowered registries. They enable organizations to be part of the problem-solving and understanding of a given condition, and they help us better understand our patient population, including the care that they are currently receiving. They aid in characterizing our diseases, as well as advancing drug development. And ultimately, our goal is to improve care and treatments, which must be in collaboration with our treating physicians who focus on our disease. And unfortunately, for most diseases, data that belongs to the patient that may be in electronic health records is often siloed rather than being used to advance our understanding of disease and research for treatments. But this is changing. You can go to the next slide. And Kenneth talked about this 21st Century Cures legislation, which not only included mandates for FDA providing guidance around real-world evidence, but also was a watershed moment for patient data that occurred within the bill and the provisions within the bill. It mandated new rules around health data sharing, allowing for more access and interoperability with health IT systems. And what this legislation does, it really does prevent the blocking of this data so that if a patient wants to consent with a third party, for instance, that their data be used to advance research in their condition, and that they should have the right to do so and give consent for that data to be shared. And I'll talk a little bit about this more later on in my talk. So you can go to the next slide. So let's talk about data. And Kenneth talked about this as well. From the patient advocacy perspective, I wanted to lay out some of the types of data that we're looking at and have been integrating into our registries that could be considered real-world data. And not real-world evidence, but real-world data to start. I think it's an important distinction that Kenneth helped lay out. First, patient-reported data. Data is directly reported by a patient or a caregiver and could be anything related to the condition itself. It could be their genetic mutation. It could be where they're receiving care, where they live, obviously, background demographics, et cetera. But then there's patient-reported outcome data. And these are really tools used to assess a patient's health status at a particular point in time. Many times these tools are validated and used widely by both clinics and registries. You then have other sources of data like clinic reported data, where a clinic could have a registry in place for their patient population, and they're collecting data on their population, and then electronic health records that exist in these institutions. And then there's claims data, which allow for interrogation of data around what payers are paying for, essentially, whether that comes from equipment or medications or surgeries, and you can do modeling with that data to better understand things that link to the natural history. So for patient registries, I think it's important for us to really look at, what are the goals of your registry to begin with? If you're just starting or you're developing a registry in process, are you hoping to create a sort of a natural history of your disease? Are you involved in understanding approved therapies? Or baseline stuff like trial recruitment, understanding where your patients are, or providing them with assistance for services, et cetera. I think it's important for us to understand the realities of informed consent and making sure that those who are participating in your registries understand what their data is going to be used for, how it's going to be used, and that the informed consent is clear. Do they understand what they're consenting to? And then accessibility. How can we ensure the data is shared widely and more easily? So some of the gaps and challenges for patient registries from our perspective in Duchenne alone, some of the patient-reported outcome measures that are implemented in the clinic are not really sufficient or do not measure what's meaningful to patients. So we're on the process of developing new, more sensitive patient-reported outcome measures, and the caveat there is you need agreement from many who are collecting this data on which measures to use. So more challenges being, if you're going to collect data for real-world evidence, for real-world data, is there common core data set that's being used across, whether it's a clinician registry or a patient-reported registry? And there's lots of differences with those two things, and the longitudinal power is important. Is there consistent data collection over a period of time so it can be analyzed? Let me go to the next slide. You can go to the next slide. Yep, Duchenne Registry. So we launched the Duchenne Registry, and you can actually go to the next slide, which does an overview of this. In 2007, there was no patient-reported registry in our space at the time, which is why we wanted to get this up and running. Many times your registry will reflect what's happening in your clinical development space and the needs that the registry could fulfill or fill gaps in. So we set this up because there was no patient-reported registry. In 2007, we set it up in collaboration with Emory Genetics, as well as the Center for Disease Control, who gave us initial seed money. And as I mentioned, this is patient and caregiver reported directly. And we're part of a larger network that around the world that collects common data elements. And that's so important in rare disease, where every patient matters and you need to find out all you can about those patients. And on the right, you just see those general registry aims that we have to advance drug development, recruit for trials, provide resources. We provide free genetic testing, including carrier testing. We have some tools on clinical trial decision-making, and ultimately we want to inform the natural history of the disease and collect this data in a timely manner and share it with all the stakeholders. So you can go to the next slide. All right, so just a snapshot. We have around 5,000 patients in our registry, primarily because this is a disease diagnosed in childhood. A number of those registrants are caregivers of people with Duchenne. And there are patients with the less severe form of the disease called Becker muscular dystrophy. Duchenne is really a spectrum disease where patients fall on various ends of the spectrum of the severity of progression. We also have carriers in our registry. You can go to the next animation. And the next, we can fly through these. So we have a diversity of patients from across the world, primarily in the US, but we have representation from well over 100 countries, and the highest numbers are on the screen there. And then our mutation, our disease is characterized by a mutation in the gene. And what we found was a really clear match of the mutation breakdown to what we see in natural history studies to date. You can go to the next slide. So just a look at some of the registry modules we have wanted to make sure that we're mapping to what's collected in natural history and have questions that are appropriate for our patient population. Patient-reported data is data that is critical, but it may not be appropriate to ask the same exact questions that, say, happen in a natural history study, like a 6-minute walk test. Most patients can't just report off the top of their head what their latest outcome measure test report was. So we've done a lot of work, including focus groups, talking to clinicians to make sure that those modules that you see on the left reflect what's important to patients, but also what would be helpful to advance research and care. And we publish on this. We've had over 16 publications. We recently did a 10-year report. and we make sure that this is disseminated and made open access to as many people as possible. So the next slide. So as our registry has evolved, we really have looked at how do we combine numerous data sources, not just patient-reported data, which has its own limitations, but as 21st Century Cures was passed and this new way to get at data, health-specific data around the country, and the power for the patient to consent to using this data came about, we also had newly approved therapies. All these things were happening. Our worry was, is data going to be once again siloed? So we built this Duchenne Outcomes Research Interchange to essentially be a data hub. And there you see sort of this combination of different data sources coming into one place so it can be analyzed against each other, both our PRO, clinical EHR data, and then post-market surveillance data all in one place. So you can go to the next slide. So electronic health record data is something we have been interested in pairing with our PRO data for a very long time, and technology has finally got us to a place where we're able to now do this. And we are starting to onboard our first 3 sites. There you see, it's a busy slide, I know, but just how the process works. We work with the clinic directly to provide them a grant, to really get their IT services set up to put together what's called an API. So that's sort of the pipes from one source of data to where the data is going to land. And we work clinic by clinic. The patient goes in through a consent process. They're told what we're trying to do and what our goals of the registry are. And they provide us consent on the ground. And then the institution shares those core data elements over to our new data hub, the interchange, where we will be able to combine all these data sources, link them, and really try to understand what's happening in the real world with patients, whether that's for their standard of care visit or if there's a new therapy on board, whether or not that therapy is actually having an impact. And then it's gone through a data validation engine. And as I mentioned before, we're starting to enroll 3 sites to get us going. Let's go to the next slide. I think this is one of my last slides, actually 2 more. So one of the reasons why we chose Prometheus Research, which is now working under IQVIA, was a partner in our space, QRSMA, is a different rare disease, but we actually share the same physicians. Our patients are seen by the same physicians. We work with similar institutions. And QRSMA demonstrated the ability to use this newer technology to extract electronic health records, and they're now up to around 30 clinics. And when we began this process and put out an RFA, I think every IT company said to us, yeah, we could do this, it's easy. And Prometheus was the first to say, it's not easy and it's expensive. So we trusted their opinion, and we saw them demonstrate what they demonstrated with QRSMA. And we built this partnership with QRSMA because in rare disease, you really do have to partner across other rare conditions and share learnings so that they can improve the way they're doing work and we can improve the way we're doing work. And in the case of QRSMA, they didn't have a patient-reported registry like we did, and we didn't have the electronic health records piece. So we've been sharing intel and really collaborating on a number of levels. We've been very pleased with that collaboration. We'll go to the next slide. So where does this data all go? One of the problems I mentioned before was the siloing of data. And when there are efforts outside of real-world data that are underway that we're very proud of, 2 consortiums that have been developed, one with the CPATH, Critical Path Institute, and another with a more private company, the Collaborative Trajectory Analysis Project. And the goal of these 2 projects is we've had many trials to date in Duchenne. A far number of them have failed, more so than have been approved, which is just the nature of research and developing therapies, unfortunately. But you learn a lot. And within those studies, there are placebo arms, which are essentially giving us information on natural history of the disease. So the idea here was, can we combine natural history data that exists in studies as well as placebo arm data and do some data modeling on our disease progression? And CTAP, which is on the right, is also looking at similar data sets and trying to understand disease progression trajectories. All of this is to aid in doing trials better, more efficiently, and hopefully reducing the placebo arm at the end of the day. And our goal is for the data that we're collecting around real world data that will have more real world evidence when we do the analysis at the end of the day. And then it could be integrated into a data sharing model such as these two that are shown. So with that, I think I'm going to be handing it over to Mark Gallagher from St. George's Hospital NHS Trust.
Thanks, Ryan. And before we turn it over to Mark, I think your last slide was just a really great reminder to all attendees. Please continue to send your questions in via the engagement panel. We're going to be collecting them and sharing them with the panel towards the end of the session. So with that, I will now ask Mark to join us and share his presentation.
Okay, thank you very much. Thank you for the invitation. This is really exciting. We stumbled across an idea a few years ago. To be precise, besides a cardiologist, I'm an interventional electrophysiologist. That is to say, I spend most of my days implanting pacemakers, implanting defibrillators, and above all, doing ablations, most of which are for atrial fibrillation. Now, to do an ablation for atrial fibrillation, we place catheters in a vein at the top of the leg. We advance those into the heart, and we burn a lot of the areas that trigger or sustain the arrhythmia. Most of those are around the back of the left atrium, which lies right up against the esophagus. So the trick with these procedures is to do enough burning to cure the arrhythmia without burning right through to the esophagus. Because if you burn not just to the esophagus, but right through the wall, there's a very high probability that that will kill the patient. It's a rare complication, about 1 in 2,000 ablations, but when it happens, it is mostly fatal. So we try very hard to stop it by avoiding delivering too much energy, by putting thermometers in the esophagus and cutting down the energy whenever we see a temperature rise. But all of those are fiddly things. And despite all of those things, we still have this complication in 1 in a couple of thousand procedures. So we've given a lot of thought to how to prevent it. People have tried injecting cold water into the esophagus during ablation. But of course, there's a very limited amount that you can do. You can't give someone a liter of cold water during a procedure. They'll fill up their gastrointestinal tract. It will cause problems. So I was talking about this during a case on one occasion, talking about perhaps putting a balloon into the esophagus and putting in flowing cold water through that. And the anesthetist who was supporting me for the case, Dr. Al-Subai, who's listed on our publication, he said, but we're using a device like that just down the corridor in intensive care. And so we bought a couple of these devices to try it out. I'll just take the next slide there. This is just the sum of a few small trials that were done with injection of cold water into the esophagus. Several trials examined that. Most of them found it to be borderline useful. When you amalgamate them, they show a significant effect. So this is the device that was in use in intensive care. The Enzo ETM, made by a small company in Chicago. The Enzo ETM is essentially a double lumen tube, and water is pumped through it, down one lumen, back up the other lumen, and back to the machine. And that water is thermostat controlled. Now the device is used, it's approved, it's in routine use in intensive care settings for people who are vulnerable to hypothermia, for example, people who have extensive burns, or for people who are vulnerable to an excessively high body temperature. In which case, of course, it's irrigated with cold water. So it can be used to raise or lower the body temperature. Thermostat controlled, so you can set it to 42 degrees if you wanted to warm someone, as cold as 4 degrees if you wanted to cool someone. If you set it at 4 degrees, you'll cool the body by about 1 degree per hour. Now, we didn't want to cool people, not their whole body, but we did want to keep the esophagus cool while we were burning right next door to it. So this is a nice, simple tool for doing that. In the next slide, you just see an illustration of how it works. It just sits in the esophagus. For a patient under general anesthesia, that's very safe. This thing slides down the esophagus perfectly easily. And you can set the temperature of the lumen of the esophagus wherever you want it. We'll take the next slide. So we tried it out in practice, and the makers of the device heard back from our local representative what we were using it for, and they were interested. So I met the inventor of the device, Eric Kolstad, and we decided to try it out in a more systematic manner. By the time I spoke to him, we'd done about 20 cases, demonstrated the feasibility of it. And here you see the device in the esophagus. There are 2 X-ray views here, and you can see the tip of the device sitting just below the level of the heart, right around the diaphragm. And during this shows some of the catheters in the heart. We're doing an ablation, mapping the atrium and doing a bit of burning here. I'll take the next slide. So to try it out properly, we needed to randomize people. So we decided, based on our preliminary experience, where we were getting lesions in something like 10% of the people who did not have the device, and very, very few of those who did have it, we decided 60 people with it and 60 without would give us some kind of answer as to whether it really worked, whether our initial observations were valid. So we decided we would randomize people 50-50 to have it or not have it. The people who did not have this just had standard protection methods, that is a temperature probe placed in the esophagus, so that we would see if the temperature rose and cut down the energy whenever that happened. I'll take the next slide. And these are the results. So my colleague, Dr. Jamal Hyatt in gastroenterology, also from St. George's, did endoscopies, did gastroscopies in all of these patients, had a good look at the esophagus. And amongst those who had the protection device, only 4 people had any evidence of injury to the esophagus at all, and most of those were very mild. Whereas amongst the non-protected people, we had 18 who had some evidence of injury. And principally these were mucosal injuries, that is burns that extend right through to the lumen of the esophagus. And remember that's not just a localized burn, that is something that extends right from the atrium through into the very center of the esophagus. And that is a significant result. So statistically speaking, this is highly significant for any mucosal injury, almost significant for gastroparesis, which is a disorder of the motility of the esophagus, a pretty unpleasant thing that paralyzes the stomach for a period after ablation in about 2% of cases. So we had a nice significant result here. I'll take the next slide. And it does seem to do all of this without making the procedure any less effective. And that's important because the methods we have been using, if you put a highly sensitive temperature probe in the esophagus and stop ablating every time you see a little rise in temperature, then you make your procedure much longer. If you turn the energy very low, give very small burns, then you make your procedure less effective. So the really crucial thing in this case is that we seem to have made the procedure safer without making it take longer and without making it any less effective. This is important because atrial fibrillation is extremely common. The drugs we have for treating it they're not useless, but they're borderline effective and quite dangerous. So ablation is already a much more effective treatment and much safer than the drugs. And I think this should eliminate around about 30% of all the fatal complications that occur in the course of AF ablation if our results are borne out in wider experience. And they're looking pretty good on that. We'll take the next slide. So we got this one published in Europace last year. That's a pretty good quality journal of electrophysiology, one of the top in our field. I'll take the next slide. And we're now going on to test it in a multi-center randomized trial. The device does not yet have FDA approval for this indication, routinely used for body cooling or warming. Quite common off-label use now for this indication based on the results that I've just presented. And hopefully the multi-center trial with 300 patients that we're currently embarking on, hopefully it will validate that result and enable FDA approval for the device in this indication. And that will probably really mandate the use of this device for AF ablations just to keep it at an acceptable level of safety. Okay, thank you very much again.
Hey, thank you so much, Mark. You know, I think this is really going to be a good topic for the panel to talk about how studies like this can fit in with real world data, real world evidence, and sort of build that picture all together. So thank you for sharing your clinical and your research experience. Next up, we're going to hear from Anita Stewart from Blue Cross Blue Shield of Illinois to share the payer perspective. Anita?
Thank you. Good afternoon, everyone. I wanted to speak really about two factors. Both of our prior speakers spoke of real-world data as well as real-world evidence. Payers use both. And I say that only to drum home the picture that when a provider is requesting a particular procedure, that particular procedure is coded, and also they're putting in a request for a particular type of procedure. That procedure is bumped up against what we would call medical policy. And medical policy is just really fancy words for the clinical data, established, statistical, large study data showing that this particular drug, this particular procedure has been found to be effective, has this risk-benefit analysis. However, on the other side, there is real-world data, and that is even a larger pool. As you can imagine, payers receive thousands of claims a day, and all are based on CPT codes. Some may have clinical evidence attached or information. Some information may come in through electronic medical records, as was stated by our prior speaker. This large pool of information that we have, we're able to characterize it. Every insurance company characterizes the data that they receive. Not only their claims, they look at length of stay, they look at certain types of diseases, your risk scores for various types of lines of business based on whether you have, say, a diabetic or a diabetic with nephropathy. So we have at our disposal all of this data. The problem, however, is it's in small, minute bundles, especially on the real world data side. So it's not in and of itself very useful to us as a health plan only to tell us well, you're spending this much on this particular claim or procedure. This particular claim or procedure had a length of stay of X when another claim had a length of stay of Y. And that's really important because it sort of further drives how we look at requests that we get from providers. Many times providers will ask for off-label use of pharmaceuticals or procedures. And because there has not been what you typically think of as a true clinical trial with a large N, then there's no real established risk-benefit analysis for this data. And many times, based on that, procedures cannot be approved. And this is the point that I actually would like to drive home. Just because it is not approved at that stage, there are other levels and some other key factors that we have to remember. And that brings in the point of conditions being rare. So if a condition is so very rare, very difficult to get that N that you're looking for. If that condition is very rare, very difficult to say what the risk-benefit analysis is, or when the provider has tried, and typically this is what we see, has tried everything to no avail, but there have been some small studies in which X procedure did appear to help in 5 out of 20 cases. So that's when it becomes significant. Then a risk-benefit analysis goes into play as to whether or not there are any other options for this particular patient. What is the outcome? Have all known standardized treatments been tried and failed? So this is where it becomes very important. I also bring this up such that everyone is aware that if you're going to be an advocate as a provider for your patient or the patient themselves, you must know what your benefit book entails, because it outlines each step that you would have to take if you don't agree with the process that has occurred. So that's very important. And this may vary from state to state. The other thing that I wanted to point out is, and we haven't talked about this issue so much, is equity and inclusion. So we have these large data sets, but it's very difficult to provide information with any consistency as to race or ethnic group. So to say that this can be seen in all groups, you can't really say that. We already know from an equity standpoint that many algorithms are or have some implicit bias within them. So those are also roadblocks or issues that we have to consider when talking about data. The last thing that I'd like to bring up when we start talking about data is a problem that we always face, is that, and our prior speakers also mentioned this, is that data is siloed. So I have all of these pieces of claims information. I can't give them up to anyone without a consent unless under special circumstances. And then there is the idea that down the street is another insurer who has a similar phenomena, and they have bits of data. Now, you may not have a complete record of this particular patient at your disposal, so you don't have all of the information. And one of the other things is that we have, in some cases, from some large groups, we have their electronic medical records, which we can download into the system. But that is not across the board, nor is that information complete. So that in and of itself poses a problem. The last thing that I'd like to mention is, yes, data is siloed, but you have to also remember there is a cost for one institution to talk to another to obtain that data and feed it back and forth. Every time you take in a new piece of data from a new client, there has to be a system modification, and that is a cost that has to be borne by someone. So that is what I wanted to bring to the forefront, that we too have data. Data is isolated, and that insurers or payers have both at their disposal and use both. If there are no questions, I'll turn it over at this juncture to Stacy Lloyd from the AMA, who is the Digital Health and Operations Director.
Thank you, Anita. Hi, everyone. My name is Stacy, like she mentioned, and I am the Director of Digital Health and Operations at the AMA. And prior to that, held various roles in operations in finance and health systems as well. I am also a board certified patient advocate and currently serve as vice chair for the VHL Alliance Board of Directors. VHL is short for von Hippel-Lindau disease, which is a rare genetic disease that involves the mutation or deletion of the VHL gene, which is actually a tumor suppressor gene. So it causes patients to grow tumors in up to 10 different areas of the body. And I myself have VHL along with 7 other members of my family. So healthcare is really important to me, both professionally and on a personal level as a patient. The VHL Alliance is the largest funder of VHL research and also created a natural history registry called My VHL. So I'm really looking forward to sharing some perspectives today from both my professional and personal life. I would echo, my fellow panelists' sentiments around the importance and promise of real-world data. The insights that can be gained are incredibly valuable to enhancing the understanding of how new medications or treatments work in varying populations and demographic groups, and without restrictions on other factors that may influence the impact in a controlled trial. This move to real world can increase access for patients who also do not fit that profile for original trials, and has enormous potential in increasing our understanding of outcomes for patients beyond the academic environment, which most of these are undertaken in. So in general for the AMA, the AMA as a whole supports the generation and use of real world data, specifically to evaluate effectiveness and safety of medical products while assuring patient privacy and confidentiality. You'll probably hear me talk about this a little bit throughout because there's certainly been major advances in terms of 21st Century Cures Act and removing some of the things that were blocking information from patients, but we also do want to make sure that that data is protected and it is kept confidential. Also to improve regulatory decision-making, decrease medical product costs, increase research efficiency, advance innovative and new models of drug development, and improve clinical care and patient outcomes. So physicians are very crucial in the development of real-world data because a significant amount of which they actually help to generate an impact through clinical encounters documented in electronic health records, patient surveys that may end up in the health record or outside of the health record, development and participation in disease or specialty specific registries through their associations or societies, as well as through other digital and mobile health products that may be used to deliver or manage care for patients. The collection of real-world data is certainly perhaps easier with EHRs being widely adopted at this point. There are a few things researchers and clinicians and physicians really need to be careful and aware of. Again, going back to that, ensuring patient confidentiality and privacy, given all of the data that is collected in EHRs. And we certainly want that interoperability, and we want patients to have access and the right people to have access to data. But we ultimately want to make sure that it's a very transparent process and patients are aware of where their data is at and who it's being shared with. And then also really important, in the physician community is the data collection burden. We don't want to increase that with the collection of real world data. Administrative burden is already a very hot topic, and we want to make sure that we're not adding burden to clinicians that are providing care. That's already been certainly a concern, a reason for some of the burnout levels that we've seen across the physician community. So definitely want to make sure that we're being very careful about what the amount and how we're managing and collecting real world data, what the impact is on that physician community in terms of how it is delivered to them and how they are responsible for managing to that. Additionally, some key requirements for physicians in using real world data, like any data used for decision making, is the quality is critical. So the AMA actually also has policy that strongly supports adequate funding of data infrastructure to allow for transparent data management capabilities, improved access to data for clinicians, especially physicians, as well as researchers and other stakeholders. And this includes, making those data systems interoperable, like many of my fellow panelists have mentioned, and then improving the reliability and the relevance of that data. There really hasn't been, at least from our perspective and what we've learned from the physicians across the AMA, not a whole lot of widespread use of real world data in clinical practice, but the AMA continues to support physicians by providing educational resources to further understand real world data potential use and impact. And I think some of that has changed with COVID and the expedited way with which we've all, as a healthcare industry and system, have had to innovate quickly. But for it to especially be useful in a clinical setting, study aims and findings need to be with clinicians who are caring for patients, need to be made available to them, need to be made available to the patients whose data is being used as well. Because in doing so, that really allows us to tap into that potential of like a learning healthcare system on an ongoing basis. Also want to kind of put on a little bit of my patient hat here, because real world data is incredibly important and it can help potential treatments get to patients faster, lower costs, empower patients to be a part of their healthcare journey, and also positively impact others. There are so many opportunities available to patients now to contribute to real world data, especially through technology. And this allows for tracking of information outside of that clinical setting. And that brings in some really unique insights into the day-to-day of someone's life versus just a snapshot in time when they're in the doctor's office or they're in a clinic or a hospital setting. I think worth noting that this increasing number of types of technology like smartphones, mobile applications, remote monitoring devices, it definitely offers innovative ways to connect patients and providers and drive engagement and development of real world data. But to Anita's point, there are definitely some barriers to access to some of these types of innovative solutions. Low health and digital literacy, concerns about privacy protections can limit patient-generated health data collection and use, and sharing from patients and caregivers. So making sure we're not actually limiting what we're collecting to certain patient populations that are either comfortable with it or able to access those types of devices or solutions to be able to generate some of that data. And then I'll close my opening remarks with a little bit of a real use case of the power of real world data for patients. As recent as September, the FDA approved a drug for VHL, the disease that I have, and it's actually the first drug therapy available to VHL patients. It was approved for manifestations or tumors in the kidney, brain, and pancreas. However, the real world data collected during that recent clinical trial that's been going on over the last couple of years actually is helping to impact physicians' decisions around when, how, and to whom they should suggest the drug therapy to, even if they don't have one of those primary indications. And that's because they're able to reference the data from the electronic health record for trial patients that had tumors in other areas of the body due to VHL. This is a massive win for our patient community since prior to this drug, the only course of treatment is surgery, which is often difficult to recover from. It comes with additional complications and it's been extremely expensive. So what's also been very positive about this experience is the members of our community, our patient community, often because they're so engaged in their care, know more about this drug than the clinicians treating them. So they've been a really helpful resource in disseminating this exciting news across the medical community in collaboration with our physician and clinical trial leadership. So the real world data collected during these original trials is now being used to treat patients quicker, but also help us to identify the next phase of trials to expand beyond primary indications. So again, really excited to be here today and look forward to the discussion. And I'm going to hand it over to either Claire or our moderator, Ken, to kick that off.
Thank you, Stacy, and thank you again to all of our panelists. I think that, we've gotten a lot of great background, a lot of great food for thought, and a lot of great food for the discussion that we'll be having in just a moment. So before I turn it back over to our moderator, Ken Quinto, I just want to remind all the attendees to please submit your questions via the engagement panel that's located on the right-hand side of your screen. We'll be sharing your questions with our panelists towards the end of the discussion. So with that, Ken, I'll turn it back over to you.
And thank you for that, Claire. I'd like to thank Ryan, Mark, Anita, and Stacy for those wonderful presentation. I'm looking forward to our discussion. So with sort of the background that's been given, I'd like to start off with you, Ryan. Can you, as patients are wondering how they can contribute to this real-world evidence, real-world data generation, if you can talk about the pros and cons of the patient registry or volunteering a patient's health data in terms of your perspective.
Sure, Kenneth, I'm happy to do that. I think we should first separate a bit patient-reported registries from registries where clinician data may be flowing into that registry. So for patient-reported registries, the pros to me have been commented on during this talk in terms of, they have the ability to empower an organization and empower the patients to be at the table, providing information in an altruistic way to really further the field of drug development and improving care for patients. They are tools for advocacy to also look at the gaps that exist in care and to inform their overall strategies for the organization moving forward. I think that in terms of the cons for patient-reported registries is, when we built our registry, the first question is, if you build it, will they come? The second question is, will they come back? Because patient-reported registries increase in their power with the consistency of the data. So patients need to come and provide you data at least annually. We actually have surveys that go out biannually so that we have a better understanding and longitudinal power to make inferences and ask questions of that registry. So that can be a limitation. Some families will come in and they'll start the process, but they may not come back. And some of that might be due to the burden of disease and the sort of, for our disease, the progressive nature of it. It's often hard to answer questions that in a progressive debilitating disease, you're answering questions around your child getting worse. So there is an emotional, toll on some of these families. And I think we have to keep in mind the questions we're asking and how important they are to advancing the research that we are trying to get done. In the sort of clinician-entered registries, where now, thanks to 21st Century Cures and the ability for patients to really consent for their data to go into data repositories, we need to look at, once again, consistency with the institutions that are collecting the data through the EHR or EMR, depending on which acronym you use. Because if the data is inconsistent with how they're asking the questions, how they're performing assessments, how the data is entered into the EMR, EHR, garbage in, garbage out. And you have some limitations on analyzing that data. So for us as an organization, we're actually working with the clinics in our ecosystem to try to get at some consistency of the measures that they're actually performing on the patients, how they're entering the data, so that when we get the data on the back end, it can make more sense.
And Ryan, you spoke a little bit about the consistency and longitudinal data, how that, the garbage in, garbage out, and having good quality data is an active effort. I would like to pose a question to Anita. How does that, the longitudinal data and the consistency and quality of data play a role in sort of your decision making, your particular organization?
In the payer world, it's, as I alluded to before, it's very difficult because you're getting snippets, bits and pieces. It is not a continuous feed. And that information is really important when you're trying to make a decision. You need longitudinal history and physical exams and lab data. And unfortunately, we don't have that. So it's very difficult. And then it puts you in the position of determining if there are any other alternatives for this particular patient. And if not, what are the small limited studies out there saying, and can something be done on a compassionate basis? So that's where it puts you. And as it was alluded to before, not all data is equal, meaning someone may code something one way, but that particular modifier is left off in another instance. So you really don't get a true picture of the patient. And that does not allow you to reach a conclusion with a reasonable degree of certainty.
And with that, thank you very much. Stacey, I'd like to just go to you and just ask, how, as being a patient advocate and obviously a patient yourself, does that sort of motivate, or how can you try to motivate the patients continuously to becoming involved, because of the longitudinal and the consistent data very much helps in terms of the quality of data that's collected. How do you see that from your patient advocacy perspective?
Yeah, I mean, ideally, I'm going to want to talk and pick Ryan's brain later after this, because it's been a challenge for us at the Alliance to engage patients and continually inputting that data every year. We do annual ones. I think we have upwards of 15 question sets. It's time consuming. And we've tried to give incentives. We've also had volunteers actually make personal calls and help patients walk through and actually input the data, and would just sit on the phone with them for hours to collect it, because it is so important to us as an organization. And I mentioned, we fund a lot of the research. So ideally, we're building this so that we can do more research, right? And we've gotten nuggets of really important stuff that have helped us develop programs and things. But, it has been a challenge to keep that maintained over time. So I think back to Ryan's point, it's really important to what are the questions that you need to ask? I think it's great that he's actually bringing in the EHR side, because we actually ask a lot of questions that would be able to be found in that data. But instead we're requiring patients to kind of re-enter or enter that somewhere else, which we could probably get it if we collaborated with, and we have an extensive clinician community that we work with. So I think there's definitely lessons learned. And I think Ryan also mentioned earlier about, across the disease organizations, you can learn a lot from each other. And, as a patient and being involved, I've learned that too, and have really encouraged us as a very small rare disease organization to start to branch out and have those conversations so that we can continue to learn and build on what we have today. So yeah, I think still a lot of work to do. It's definitely a challenge, but I think it is worth it. And one big thing that sticks with me, and this is important as a patient, but I think anyone that volunteers their time to do something, they want to feel the loop back, right? How is this being used? What's coming of it? And I don't think we do a really good job at that across this industry of like, you gave us this really important information and you're the expert in this, and this is how we're using it, and this is how it's making an impact. And I think that's probably an area we could really do a better job at.
Thank you for that. That's a great perspective. And Mark, I want to take in your clinical perspective. As you know, one of my favorite things when I got to FDA, that FDA does not regulate the practice of medicine. So how do you engage with your patients about, getting them to share their data and to engage in in your particular case, a procedure that you've had good results from, but it isn't necessarily approved by indication by the FDA? And how do you sort of go about starting that discussion and keeping your patients engaged?
So locally here, we find a very large majority of patients are very willing to participate in research, to have their data used, to go to some inconvenience for the sake of other patients, as long as it's properly explained to them, as long as the common good is evident, as long as it's not just a commercial thing. In this study, we had 80% recruitment amongst the patients approached to ask them, would they participate? Now, we did have quite a lot of dropouts, people who afterwards found it difficult to get back for their endoscopy, for example. I think people generally want to help each other. I think that's just a feature of humanity. It all comes down to the communication, to the explanation, to making people understand why this is a good thing to do. In terms of data sharing, that's a tougher one. Now, in the NHS, the National Health Service in the UK, there has been a government effort to get a large proportion of people to just rubber stamp more generalized sharing of their data. That's been unsuccessful because it really did come across as the government trying to sell everyone's data to industry. And of course, people don't like that idea. People don't like the idea of profit being generated from something that is theirs, if they're not going to share in the profit. So, altruism has to be rewarded with at least maintenance of dignity. You can't afford for people to get the idea that they're being defrauded in some way.
And you bring up a really good point, Mark, and thanks for that. And I guess I want to go to Anita for my next question, which is sort of a segue, is how could all stakeholders, including regulatory, payers, patients, clinicians, really come together to support actionable RWD and RWE, do you think?
I think the first way in which to do that would be to develop a data set that we all use, something very basic, but a data set that is common to all organizations. And that is where we would start. It would be small. And using that data set, I think we could gradually increase what we would be handling and could share. We'd also, and I think this can be done simultaneously, is we'd have to have a funding source, because as the data elements grew, there would be need for additional finances to change IT systems. So some overarching organization that would help in this regard. And then I think also, there also has to be something almost akin to an IRB that would be the guardian, meaning to ensure appropriate consent, the use of the data collected, things of that nature. So that's how I see it. Common data set, funding to ensure organizations being able to transfer data, and then a ethics group or something similar to IRB that would actually put the rules in place.
And Ryan, I see you nodding vigorously to Anita's response. Would you like to elaborate more?
Yeah, so we are currently in process of working across stakeholder groups, so clinicians, patients, industry, we have now developed a core data set. And when this effort started, the patient groups involved, because you have very many patient registries around the world that are connecting, were a bit frustrated because it felt like the clinician's opinion mattered more, and they were also lumping together patient-reported registries and clinician-entered registries. And we found this to be problematic. And it was mentioned before about the types of questions that, and I think it was Stacy who said, you know, we had to take a hard look at, with our over 10 years of data, what were the questions that were difficult for patients to report on? You know, a forced vital capacity score from a therapy assessment is not something you just remember off the top of your head. However, we're looking at activities of daily living, things that, what are patients able to do, things that are meaningful to patients, and ensuring that those questions are asked. However, if those same questions aren't being asked at the clinic for these patient-reported outcome measures, then you have a mess of data. So we've had to really look at what are the questions being asked so that we can ask it consistently across all registries, not only in the US. In rare disease, it's important to look globally.
Thanks, Ryan. And I'm going to move on to some of our attendee questions, and I'll start with you, Mark. One of the attendees had a question of how can patients opt in or opt out into, in your particular case, the studies that you're conducting.
So for randomized studies, it's really, they have the option of opting in. We approached every patient coming for an ablation with one of the physicians who is participating. We explained it to the patient, and each patient had the option of participating or not. And so it's that's very much, I mean, everyone gets the offer, everyone gets the explanation. They can decide to participate or not. So there's no baseline assumption. I think that's general.
And Ryan, I'm sorry, Mark. Thank you for that. And Ryan, can you just comment briefly on how patients can get engaged in your particular registry, or how you recruit patients and their families?
Yeah, so we do have an IRB in place, and we go through a rigorous consent process. And we took a lot of time through focus groups and other sort of methods to see how do they interpret the language with informed consent, and do they understand how the data is going to be used. And they can opt in or opt out. And the same goes for if they're going to go through our EHR extraction. The clinicians are provided materials to explain what we're trying to do, and ask questions as to, do they understand what the informed consent means, and that they have the ability to opt out. So, I mean, those are some of the practices that we have followed, and it was mentioned before by Nita. I mean, having the IRB in place is critical. If you're going to do a patient registry, you really have to have that so that the patients are also protected.
And Stacy, do you mind either adding AMA's perspective or your personal perspective as a patient and patient advocate?
I don't think anything's different. I mean, everything that we do, even research-wise through the AMA, we run through IRB when it involves any human subject, and anyone has the opportunity to opt in, opt out. The user agreement or the agreement that you review, prior to engaging in anything would be that, you can reach out and have your data removed from this study if it's identifiable and things like that. So very similar to Ryan, both I think from an AMA perspective in the research even we do, but also at the Alliance on the patient side as well.
Great, thanks. And so this is our next question. I'll read it and let anyone else chime in. So what do patients need to bring to their clinicians to help with their decision-making process for the RWD or RWE component that clinician may be involved in? I'm not sure I stated that question particularly great. You can feel to ask clarification if needed.
I mean, I can start just from some recent experience because we've had a lot of patients in the VHL community. We have a really active private Facebook group for VHL patients and families. So a lot of the patients that were going through the clinical trial would share their experience on there, and other patients got really excited. And like I mentioned, our patient community has actually been a disseminator of the FDA approval of this and how it's being, approached in clinical practice to their own medical teams who, are then kind of reaching out to the Alliance and our physician community that is aware of the details of the drug and everything to get more information. So I think, patients just need to do their research, stay engaged with their care, and also can ask for resources from, organizations like the Alliance and what Ryan works on. These disease-specific organizations oftentimes are the most resourceful places to go to get information to kind of arm you with what you need to empower yourself in a conversation with your doctors.
All right. There were a couple of FDA questions I'm going to try to address quickly from the audience. So FDA is basically reviewing the RWE/RWE that's submitted by drug sponsors for a new indication. I've been in my position for about 3 years, and one of the things that I feel is most powerful about RWD, RWE is the ability to include those who have not been able to been normally included in clinical trials, such as people of color, people with access issues, lower socioeconomic status. So I feel like one of the greatest powers of RWD/RWE is being able to include those sort of communities that we've overlooked in our clinical trials when FDA approves clinical trials. And I think that's one of the real powers of real world evidence, and that's why I'm always excited about being able to include those communities. I want to wrap up here. I do want to go around to each of our panelists and see if they had any concluding thoughts, and if they had any particular point they want to make about what they knew patients, what they wanted to know patients about RWE or RWE. Anita, why don't we go with you, start with you first.
Well, I'll sort of pick back up on the issue of equity and communities of color. There is mistrust, and that's historical and will take quite a bit to overcome. So when you start talking about clinical trials, new therapies, registering for transplant donations, etc., that is a huge burden, and one that is not overcome in one setting. So it is very difficult. Then the other obstacles that have to be broached would be those that might impact one's ability to get back to the medical provider, whether it's transportation, working odd shifts, inability to have paid time off. These are all factors that limit minorities from participating in clinical trials. So that's something we all have to work on in terms of building trust and improving outcomes for all.
Great, Mark. Thank you for that, Anita. Mark, why don't we go with you next?
I just want to thank the organizers again for the invitation here. I think this process is immensely important. Medical technology can be very top-down process, potentially controlled by a government and a small number of very large companies. It's so important that people, individuals actually delivering care, have the ability to innovate using existing products, whether that's devices or pharmaceuticals, to innovate and pursue new channels that are not necessarily expensive, and do so in a way that doesn't require a multi-million, multi-billion investment. So there's a lot in this process that's very important to a large number of people. Thank you.
All right. Thank you very much, Mark. And Ryan?
Yeah, thank you for the opportunity. I know that there's going to be some follow-up. I'm going to be pinging our other speakers just to connect offline because I learned a lot from them today. I mean, I think for patient organizations that are out there thinking about whether or not they're going to be doing registries or collecting data, the power of patient advocacy organizations is the power to convene all of these various stakeholders in our drug development ecosystem. And I think that that's something that needs to be done early and often. I know that term's used a lot, but to look at what's happening in your space and understand the needs of each of these stakeholder groups and what they view as important when it comes to data on your population. And if there's a lack of consensus, trying to reach that consensus is going to be critical, and you can never do that early enough. So, I mean, I really do invite patient organizations to do that as early as possible, and I'm happy to talk to any of them offline about our own experiences and what we've learned over time.
And Stacy.
Thank you. I would probably close with a couple of things, and I'll probably start with the patient-physician relationship. And I would definitely want to bring that physician piece back in. But the best thing I ever did was, and it can be scary, and there's likely, you know, if you're here as a patient, you probably are interested in the development of drugs or the use of tools for a reason, right? And it's important to your health. And taking ownership of my healthcare and getting involved, actively involved in my care, has allowed me to be a more informed patient, ask the right questions of my physicians, find the right care teams that are a good fit for me and that know the disease that I have, and just be more generally knowledgeable about what is going on with my body. And I think that helps actually to build a really strong physician-patient relationship that ultimately, you know, ends up in the best outcomes. And, you know, collectively together, you are generating that data and that evidence and being a part of the solution to whatever, you know, health condition or disease you might have. And the only other thing I think I would say is I'm really hopeful that the acceleration of innovation that happened over the course of the last year, and my head goes to things like telehealth and a lot of the digital technologies and things that we've had to cope with and adjust to through the pandemic. I'm hopeful that that kind of accelerated pace of innovation, you know, is able to be withstand, of course, with the safety and quality that we need for those things to be. But I think that's really something that is going to be important and will help us get treatments and, you know, care to patients a lot quicker if we continue to innovate at that pace. So I'll leave it at that.
And I'd like to thank our panelists for the wonderful discussion this afternoon, or whatever time it is, and I'd like to toss it back to Claire and Barbara. Thank you.
Wonderful. Thank you so much. This was a really intriguing panel. It was exactly what all of our organizers were hoping for. And not only thank you to Ken for doing a wonderful job moderating, but to all of our speakers who provided such important perspectives for us. It is a wonderful reminder of patients and their caregivers to be proactive and engaged, and also to bring all the people around the table and expand the table for those who don't always know that there's opportunities to engage in real world data, especially in communities of color who don't always know what's at the table. So thank you all so much for sharing this today with us. Now I'm gonna hand it back to Claire, who's gonna turn it over for the next portion of our program.
Thanks, Barbara. And I will just echo the thanks to Ken and to all of our panelists today. So now for the last part of the program, we will be awarding our 2021 Global Health Repurposing Awards. This is the 9th year that we have recognized leaders, repurposing leaders in the areas of philanthropy, industry, and research. And what makes this year really special is that not only were these organizations working to create patient impact through repurposing for several years, but then during the past year and the COVID-19 pandemic, they were really able to pivot their efforts, their repurposing efforts, to focus specifically on COVID. So you'll hear a little bit more about who these awardees are and their achievements in just one moment. We will start with the Golan Christie Taglia Patient Impact Philanthropy Award.
Cures Within Reach presents the 2021 Patient Impact Philanthropy Award to CureID. This tool from the FDA and NCATS at the NIH allows clinicians and researchers to share repurposing case reports as a means to identify drugs for further study in clinical trials. We honor the development and launch of CureID for infectious diseases and soon for other diseases as well. We especially recognize the enhancements that the FDA and NCATS at the NIH made to CureID to help assist in the ongoing COVID-19 response. CureID is an example of the government's critical role in the repurposing ecosystem and the FDA and the NIH's longtime commitment to enhancing drug development for difficult to treat diseases. Congratulations to the entire CureID team.
It is really my great honor to be receiving this award to recognize the work that's being done in repurposing. This was a platform that was begun in 2013 as a case reporting tool from clinicians and has expanded in many of the areas that were talked about today amongst your panelists in terms of patient engagement, use of digital health tools, electronic health record extraction, and other ways of collecting data that can be used for hypothesis generation. The opportunity that drug repurposing presents to identify treatments that could be helpful for patients lacking adequate approved therapies is immense. And that's what our team has really been focused on, is how to benefit the most patients with the greatest unmet need. So I would like to thank all of the many members of our team. As I said, this is really a joint effort begun by FDA's Office of Medical Policy and then the NCATS National Center for Advancing Translational Sciences at NIH. And now in partnership, our public-private partnership that was formed actually near the start of the pandemic and really helped to launch our efforts in the COVID space, the Cure Drug Repurposing Collaboratory, which is housed by the Critical Path Institute that was mentioned in the Duchenne space as well. I think having these conveners who can bring all of the stakeholders together makes this all the more powerful. So thank you so much for this recognition. We're very grateful and appreciate the opportunity.
Fantastic. Thank you so much, Heather. We're so proud to recognize the work of CureID and the whole team that was involved in the creation of this tool. So now we will be moving on to the Patient Impact Industry Award. We will be watching a little video about this award and then hearing from the recipients.
Cures Within Reach presents the 2021 Patient Impact Industry Award to Eli Lilly and Company. We honor Lilly's ongoing commitment to improving the lives of patients with unmet medical needs. During the COVID-19 pandemic, this has been through its support of baricitinib, an existing rheumatoid arthritis medication to treat certain hospitalized COVID-19 patients, among its other initiatives. Baricitinib has been authorized for emergency use by the FDA in combination with remdesivir. In addition, Lilly has continued to test already approved therapies for new indications, including duloxetine for fibromyalgia and ramucirumab for various cancers after it was first approved for stomach cancer. Congratulations to the entire Eli Lilly family.
Hello, my name is Robert Baker, and on behalf of my company, Eli Lilly and Company, I am very pleased to accept the 2021 Patient Impact Industry Award from Cures Within Reach. My role at Lilly is Deputy Chief Medical Officer, and there I'm accountable for the conduct of our medical research and design of our clinical research, as well as medical quality and decisions like whether we advance medicines into individual humans for the first time, and if they make it all the way through testing, how we label them for the prescribers who will use them. Lilly was founded 145 years ago, focused on trying to improve the life of patients by discovering and marketing medications that will meet unmet medical needs. We've continued that to the present day, and as we've done that, one approach has often been to take medicines that will work for one type of patient and test them for other conditions. Often that doesn't work, but in some cases it brings as much or greater value as the original therapeutic target. So when the pandemic hit in 2019, we reviewed our portfolio and took several drugs and began testing them to see whether they would assist society in dealing with the pandemic that we have and are facing. It is that work that's being acknowledged today, and we are honored to receive this Patient Impact Award. We admire the work that Cures Within Reach performs, and like other honorees today, are pleased to be recognized. Thank you again for recognizing Lilly with the 2021 Patient Impact Industry Award.
Thanks to Robert and the entire Lilly team. We know that you will continue to use your arsenal of existing therapies to help patients for years to come. Finally, we have our Janet Davison Rowley Patient Impact Research Award, video first, and then followed by our recipient.
Cures Within Reach presents the Janet Davison Rowley 2021 Patient Impact Research Award to ReFRAME, part of Calibr at Scripps Research. We honor the impact that this screening database is having on patients with neglected diseases, as well as finding potential COVID-19 treatments. We celebrate Calibr's commitment to this database's ease of accessibility and the collaboration made possible through this technology, especially during the ongoing pandemic. Since ReFRAME's launch, repurposed drugs such as clofazimine in cryptosporidiosis and Oranafin in tuberculosis are impacting patients in clinical trials. Congratulations to the entire ReFRAME, Calibr, and Scripps team.
Thank you very much to everyone at Cures Within Reach, all of Barbara and Claire and all of the people who've been involved in sponsoring the work. Very much appreciative of the opportunity to receive this award on behalf of many of my colleagues here at Calibr and Scripps Research Institute. We built the ReFRAME compound collection starting in 2015 and have initiated several clinical trials based on it in the hopes that we can include every small molecule drug that has been safely tested in humans to repurpose them appropriately. I think this is really valuable. I think based on what panelists and others have discussed today is really, it's critical for us to be able to include as many of these compounds. Nearly half of these compounds are in fact not available commercially, so we've actually been able to make them ourselves and include them in the collection. Obviously, the Bill and Melinda Gates Foundation, who sponsored this work, has been essential to making this happen. And obviously, with the speed of the pandemic and then also the ability to distribute this compound collection as early as January of 2020 to collaborators in Hong Kong, speak to the ability to be able to repurpose effectively and efficiently. And in cases where we can't, understand where we need to develop novel drug entities. So I'm really excited and appreciative of all of my coworkers and collaborators here at Scripps, all of the many groups who've screened the ReFRAME collection, including folks within the Cure Within Reach network, and looking forward to sharing the collection, sharing the data in real time, and bringing the best opportunities to patients.
Wonderful. Thank you so much, and congratulations again, not only to our 3 awardees this year, Cure ID, Eli Lilly and Company, and ReFRAME at Scripps and Calibr, but also thank you to our speakers and moderator of our earlier event on real world data. Again, congratulations and thank you so much. I want to also thank our industry and philanthropic partners. I want to remind everyone to register for our November 9th event on diversity of clinical trial researchers and diversity of clinical trial patients as well. Thank you so much for participating today, and have a wonderful rest of your day.
Thank you.